Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hello everyone, welcome back to Cardiovascular Matters. This month in June is Men's Health Month. Happy Father's Day to everyone last weekend. We're back here with our expert, Dr. Craig Walker, and he's going to walk us through some of the health issues with men. Dr. Walker?
Thank you, Terry. You know, I am often approached by men about they perhaps have just lost a friend or someone who they felt was completely healthy, and they'll come to me and say, Dr. Walker, what should I do? You know, I'm feeling good at this point, but they may have reached a certain age, or in certain cases, they perhaps have a family history of disease. And there are tests that are very appropriate even for asymptomatic people. First, let's start with looking at things that are apt to be most common, because there are thousands upon thousands of tests, and we certainly would not get all of those.
Right.
So the first thing that I tell patients is, let's look at your risk factors. Risk factor number one, what are your genetics? What did your parents and their parents have as medical problems? What was ultimately the cause of death? Secondly, we have individual risk factors that have nothing to necessarily do with our genetics, but they play a role. For instance, does one smoke? Does one have high blood pressure? Has one developed diabetes? What is one's cholesterol? Because all of those also play into overall risk. And certainly all of these are important. So if we look at the causes of death, number one, by far and away, the most common cause is cardiovascular causes, such as heart attacks, strokes, and things such as that. Cancer is the number two killer. And we know that lung cancer and colon cancer are very common. Blood cancers can be a problem. And men, of course, are also affected by prostatic cancer, which usually doesn't kill us. However, it can cause problems, and the earlier we pick it up, the better we can certainly treat it. So these are all common causes. So if a patient comes to me and they say, Doc, everyone in my family has died of heart attacks, then the approach that I would take in looking at this would really focus on cardiovascular risk. If they tell me lots of people in my family die of cancer and I'm a smoker, then of course the workup might be different. But let's take the patient to start with that really doesn't have a strong family history of anything. Should they be concerned? Well, of course, because in today's world, our risk factors have changed substantially from previous generations. We tend to be more obese, more likely to have risk factors for cardiovascular disease. And since it is the leading cause of death, certainly if we have risk factors such as high blood pressure, high cholesterol, diabetes, or a family history of heart disease, then we would want to address that, even if they're asymptomatic, because unfortunately, often the first sign or symptom that one may have is a heart attack, and that heart attack can indeed be fatal. And all of us have known people who were seemingly very healthy who suddenly died.
Right.
Now, luckily in today's world, we have really easy ability to have a clue if someone is really at risk of this. So to start with, simple blood tests. Blood tests that I think any male over the age of 45 should absolutely have would be a complete blood count, a determination of blood fats, and in particular cholesterol and its subfractions, the things which we call lipoproteins, which carry cholesterol in the blood, because cholesterol being a fat would otherwise not dissolve in the blood, which is water soluble. So we need something which is a detergent. And these are the lipoproteins, which carry around cholesterol and triglycerides. So we would want to know if those are elevated. In the blood tests, of course, we would pick up any of the blood dyscrasias that might occur, things such as too high a red blood cell count or too high a white blood cell count, which might clue us in about certain types of cancers and other problems. But we would want those tests. We would also want a test called a high sensitivity C-reactive protein, which is a measure of inflammatory response in the body. Now, the reason that is important is people who have high levels of C-reactive protein are much more likely to have a heart attack than people who do not have high levels of C-reactive protein. So certainly, if we're looking at cardiovascular diseases, we would want these blood fats, and we would want to measure a high sensitivity C-reactive protein. Now, those are very important, but basically a history starts all of this, not just a history of risk factors, but if there are any symptoms. Certainly, if a man comes to me and he says, "Doc, my legs hurt when I walk," then that is often a clue that that person may have blocked leg arteries. And patients who have blocked leg arteries are far more likely to also have blocked heart arteries and blocked arteries going to the brain.
Absolutely.
So even though without those symptoms, part of the physical examination should be to check pulses in the feet and pulses at the wrist. If pulses are diminished, that alone may be a sign that a person has peripheral arterial disease. Now, if that patient is not hurting when they walk or not hurting when they use their arms, we would not necessarily need to do anything about correcting flow in the arms or legs. But that would unequivocally identify a person at high risk of future death, because sick legs and sick arms are almost never attached to healthy people. That's a clue that atherosclerosis is going on and certainly warrants additional attention. Now, in today's world, we have tests that really can help us a lot. The most painless and easy test, and I think one of the most underperformed tests in America, is a study called a calcium score. Now, what one does for a calcium score is lay on a CT machine, and for about 30 seconds, an image is taken, a CT image is taken of the heart arteries, the coronary arteries, and it can tell us whether there is calcium or no calcium. If there's no calcium in the coronary arteries, it is very unlikely that that person has significant coronary disease. Can one have it with normal coronary calcium? One can, but that is extraordinarily rare. Calcium in the coronaries typically is a sign that there's some atherosclerosis going on in the coronaries, and it may warrant further investigation. Certainly if one is 60 years old and has never had a symptom and has completely normal coronary calcium score, their risk is extraordinarily low that they're going to go on to have a heart attack. Just that simple. It certainly reduces the risk. If a coronary calcium score is high, it does not yet mean that the arteries are blocked, but it does mean that atherosclerosis is going on, and that person should have cholesterol controlled better, blood pressure controlled better. If there is a high C-reactive protein, that should be addressed with medicines that lower that inflammatory response and lower risk tremendously. And by doing that, we may often prevent future events. And that's really the key of screening, and the reason that people should seek out medical attention as they reach certain ages. Certain blood tests should be done. Certainly people should consider having screening colonoscopy studies, as colon cancer is one of the leading causes later on of death. And we know that colon cancer typically takes a long time to progress. It typically starts as a polyp, and over many, many years it can develop. Clearly, a chest x-ray in smokers would help detect early cancers, lung cancers. Now that's really crucial, because if we can pick up a lung cancer in its early stages, usually we can have a cure for that. However, once this lung cancer is advanced, and particularly if it is spread, then the prognosis is much worse. So there's an old saying that an ounce of prevention is worth a pound of cure. And in cardiovascular diseases and cancers, I would say that ounce of prevention is worth many tons of cure. Because if we deal with this appropriately, we can institute measures that stop the problem early on, and that results in a much better outcome.
Much healthier for the patient, too, as far as them taking control of their health versus reacting to an event, you know.
That's right. You know, Terry, I see so many people who really, and we're brought up to believe this, to think that we're invincible, and none of us are. Obviously, death occurs in everyone, but it is our goal to limit death and limit disability.
Right.
And so preventing things like a stroke, which can make us paralyzed, certainly that's in and of itself also a huge problem, not just the fact whether one can die or not, but how does it affect us? Certainly, if we can limit heart attacks, we lessen the likelihood of people having heart failure with these other issues. And so it is an issue of both preventing death, but also preventing the disabilities that occur with these disease processes. So I encourage any man over the age of 40 to certainly have at least some kind of screen. The earlier we control cholesterol, the earlier we have people quit smoking, the earlier and better that we control one's high blood pressure and diabetes, the better will be the results. Obviously, it's much like a car engine. It's much better to change oil regularly, even before the engine knocks, to stop that engine from knocking down the road.
Right.
Well, the same is true with our bodies. If we can do those measures which lessen the problem occurring, then it's akin to changing one's oil at a regular basis. You stop the problem before it occurs, and you can let that lead to a much healthier and longer life. One, not just that you can expect more years, but that you can expect to be healthier and feel better.
So back to the stroke, I mean, the strokes that are of cardiac origin, I mean, are you finding that when you just lay a stethoscope on someone, the fact they may have AFib, or you're looking at their EKG? How does that work?
Yeah, so let's look at strokes. Strokes really refer to death of brain tissue. That's what strokes are. And there are different kinds of strokes. So we can first divide strokes into those where we bleed into the brain. Those are called hemorrhagic strokes. And those are typically associated with high blood pressure or aneurysms or both. And then we have the strokes that are called bland strokes. Now, there are two types of bland strokes. Bland strokes are when blood flow to the brain is choked off. Now, those can be embolic. Embolic strokes occur when clots occur typically in the heart or in the great vessels. And those clots or pieces of plaque break off and they go up into the arteries of the brain, blocking off blood flow, resulting in an area of the brain not receiving enough blood. Often they go to the middle cerebral artery or the anterior cerebral artery, and these can be, of course, devastating and can kill us. And these are what typically can lead to us being paralyzed on one side of the body, or may end up even with blindness in certain types of strokes. But we divide these strokes into those that arise in the carotid arteries or vertebral arteries, or those that come from the heart, with atrial fibrillation in particular, which is the leading cause of strokes which arise in the heart. Arrhythmias cause the atrium in the heart, the left atrium, to just quiver rather than to pump. And as it just quivers, there's a little out pouch of the atrium called the atrial appendage. And often when that atrium is not contracting, clots form in that pouch.
Mm-hmm.
Now, as the heart starts to pump again, or even if it doesn't, sometimes that clot will migrate out of the heart and go wherever there is blood supply. So it could go to the legs, it could go to the kidneys, it could go to the gut. But since the brain gets most of our blood supply, particularly at rest, the place it's most likely to go is the brain. And so that's why people with atrial fibrillation are kept on anticoagulants long term, is to protect stroke. We also now have new tools where we can actually exclude that atrial appendage. Devices like the Watchman device, which we place into the atrial appendage, can occlude that atrial appendage, stopping it from throwing clots, which go to the rest of the body. So certainly these things can be life-changing. With strokes from the carotid arteries, and often we can listen over the carotids and see if they're bruits, then certainly we can treat those with stents or with a surgical procedure called endarterectomy, where we actually clean out the arteries, make a cut and clean out the arteries. Right. And certainly there are certain cases where one or the other technique may be better than the other, and there's some where the techniques are pretty equal in terms of outcomes, and we certainly, based on patient characteristics, can better define who's going to benefit from one or the other of those procedures. But certainly this is an area that we can do a lot with. Now, hemorrhagic strokes, as I mentioned, come typically from, the most common arise from long-standing severe high blood pressure. But occasionally they come from aneurysms in the brain that pop. And typically we have a clue about aneurysms because these are typically familial. Typically aneurysms in the brain, others in the family have had aneurysms, and that's a little bit more difficult to pick up on just a screen. There is a way to do it. A way to do it is to obtain a CTA, or a CT angiogram, as we call it, looking at the brain, and then we can see these aneurysms. Aneurysms are simply a weak spot in an artery, much like a bubble on a tire. And the risk of them is exactly like the bubble on a tire. They can explode. They can pop.
It's not.
And when they do,
yeah.
bleeding occurs in the brain. The brain is enclosed by the skull, which does not expand. It causes pressure, and this can actually, these strokes are typically more severe, and in bad cases, because of the increased pressure within the intracranial cavity or inside the skull, it can actually shove the brain down through the little tiny passage that lets the spinal cord out from the brain, and we call that herniation of the brain, and that usually results in death on the spot. So there's a lot that can be done for all of these issues, but certainly for anyone who's interested in determining what sort of risk are they at, a good history, a physical exam looking for the pulses in the neck and listening over the neck to make sure there are no unusual sounds, which we call bruits, which can clue us in as to blockages. A good examination of the pulses in the feet can go a long way for these cardiovascular problems. A screening calcium score, and the prices for that are all over the range. A calcium score in our practice is $90, but I understand it can be much more expensive in other areas.
Right.
But that scan can tell us a lot in terms of overall risk. I've also, Terry, found that necessary sometimes because it is very difficult to suggest to someone that perhaps they should start on medicines when they feel great, feel they have no risk factors, unless we have evidence that, hey, there is a problem that's occurring. And when we see calcium in the coronaries, and I show this to the patients, I said, this is the early stage of atherosclerosis, and it is very important that we stop that from progressing. It's a lot easier to tell that person, hey, you really need to quit smoking, or we need to better control your blood pressure, or we have to have you lose weight. And so we can start all of these things which make people healthier.
Well, I was going to say, it just gives you, it's a different talk track. Do you want to have an event in 3 to 5 years, or do you want to have an event in 35 years?
Yeah, or do you want an event at all? In
Right.
today's world, with some of the very powerful cholesterol-lowering medicines that we have, it has been demonstrated that atherosclerosis can reverse. I've been asked since the beginning of my practice, now more than 40 years, people have said, Doc, isn't there such a thing as Drano to clean out the arteries? And of course we don't have Drano in the coronaries. But we now do have tools by really lowering cholesterol that sometimes we can actually cause regression of atherosclerosis.
Oh, wow.
And in most people, we can have complete cessation of progression. And so that's very important. If one is doing well and the disease does not progress,
Right.
then certainly that's a major battle. But the first thing is to identify that there's a problem, set a course to arrest that problem, and perhaps in certain cases cause regression of that problem and stick to it. And again, there's a misconception out there. There are many people who say, well, Doc, I eat pretty well, I exercise, I don't think I'm at risk. Well, certainly you're at less risk if you do those things right. Mm-hmm. But that does not get rid of all risk. And we know now, as we look at, for instance, the screening studies that have been done looking for people who have blocked leg arteries.
Right.
We know that anyone over the age of 50 who has either smoked or had high blood pressure, 29% of those people, if we measure pressures in their legs, 29% of those people actually have peripheral arterial disease. We know that above the age of 70, just by reaching that age, mm-hmm. that 29% of those people have peripheral arterial disease. And that came from a study called the Partners Trial, where blood pressures were measured in the ankles and in the wrists and compared. And those people had much lower pressures in the ankles. 29% of them did. Now, you say, so what if there's not big symptoms or anything? Well, the so what is that tells you that person's at risk. Because a person with peripheral arterial disease is actually more likely to die of a heart attack than a heart attack survivor. And again, we often trivialize these issues, but they should not be trivialized. So much that we can do. And I cannot tell you how often I've found people via screening
right.
who are at incredible risk of sudden death. Because let's say that we find some of these abnormalities. Perhaps, if it's a heart abnormality that we're worried about, perhaps a treadmill test or a more specialized nuclear test, more commonly in women, because women's regular treadmill tests often have what we call false positives and false negatives, mm-hmm. cases where it appears they have the disease and they don't, and sometimes it appears they don't have the disease and they do. Mm-hmm. But for men, a regular treadmill test is a pretty darn good screen, because what we're doing is we're making that heart beat faster and stronger, and we're looking at the electrocardiogram at that time.
Right.
And we can often see changes that tell us, hey, there's significant blockage here. And those tests are really so crucial in determining what we do and determining the level of risk. Again, not everybody with a blockage needs necessarily to have bypass surgery or to
right.
even have a stent, but they all need medicines. They need medicines to stabilize things and to stop the progression of disease. We've come so far in the world at this point in our treatment, but we're far behind in identification of people
right.
who need this. And I would make a strong plea to men, certainly men above age 45, start thinking about your health. Do not believe that you're invincible, because none of us are. And get these appropriate issues. These little things that we've mentioned, these are not terribly expensive tests
right.
to do. They take a little time. But they can not only save your life, but they can stop you from potentially being paralyzed or miserable. They can stop some of these disabilities, and we simply can do better. And it has been my experience that once we find any of these abnormalities, the probability of me getting someone to take a blood pressure medicine or to quit smoking or to take something for their cholesterol goes up exponentially, and we achieve success at that time.
You mentioned something earlier that really hit home with me. I was a rep in working in cardiac cath labs all over the United States for more than 20 years, and I can't tell you how many times I would see somebody, a young man in his mid to late 20s that looked like, just a perfect physical specimen, and they'd put him on the table and do a cath on him, the heart cath, and they'd have just a profound cardiovascular disease. And if you go back up the chain of events, well, his dad died at age 50 of a heart attack, or his uncles, or so the familial thing is so prevalent. And certainly if you've got a family history of issues of those sort, that'll come out during that physical exam and history, and that leads you to be able to get patients on the right track in terms of their medications and things like that to prevent things like that from happening.
You bet. Many of those people that had died earlier, or their parents that had died earlier, probably already had atherosclerosis when they were younger.
Right.
And we can base that on many things, but perhaps if we look at data, some of the better data in terms of giving us an idea of young people with disease came out of the Vietnam War, when young military men killed in action had autopsies.
Oh, wow.
It was found that many of these men, many of them actually sub 20 years old, but many in their young 20s, actually already had significant evidence of advanced atherosclerotic disease. It was not just starting, and perhaps it could have gone another 15 years or 20 years before it would have manifested itself. But imagine if we would get to that disease earlier. And, I think that's even more magnified here in 2024 than it was in the 1970s. And I say that because our population is more obese. Mm-hmm. Diabetes is epidemic. Mm-hmm. Certainly, smoking has declined initially, but it's starting to go up again. And unfortunately, recently, after several decades of decline in cardiovascular death, it has recently started to rise again in both men and women. And so obviously we can do more. And we just didn't have the tools in the 70s that we have now. For instance, we didn't really know about controlling C-reactive protein with a pill. And you won't hear much about that because the medicines used to treat elevated C-reactive proteins are generic. They're incredibly cheap. They've been around forever. And they're medicines that have been historically used for other causes, such as treating gout. So, for instance, the medication colchicine, when we're treating gout, we give patients very, very high doses of this until they have a lot of GI symptoms, and typically the gout goes away. But the treatment for a high C-reactive protein is to use very low doses of this medicine taken every day. Mm-hmm. And that now has made it into the guidelines for treating patients to prevent heart attacks. That it's the data with this shows it's a very powerful drug. We now have better statins, and we have better drugs, PCSK9 inhibitors. These are medicines which allow us to achieve lowering of cholesterol like never before. Amongst our diabetic medicines are these new classes of diabetic medicines, the SGLT2 inhibitors as well as the GLP-1 agonists. These are medicines which have a different mechanism by which they lower blood sugar. Both of these groups of medicines also cause weight loss. The GLP-1s perhaps more than the SGLT2s. The SGLT2s have been shown to help prevent heart failure and also to stop kidney failure or to lessen the likelihood of kidney failure. And the GLP-1s to further help us control lipids. So we now have bullets for our gun, okay, that to allow us to stop some of the progression that we simply can use that we didn't have before. Now, that does not negate the fact that healthy living style is important. Clearly, exercise, watching one's diet are absolutely part and parcel of everything we do. But I would discourage, let's say, a 55-year-old man with a bunch of risk factors who may not be feeling good, to decide that the first thing he wants to do is go out and start running. That's a recipe for disaster. And I think that person should be seen first, should have a
Right.
minor evaluation. And that may disclose a problem which needs more attention, immediate attention. But secondly, it may find something that's out of whack that doesn't, that should be treated. Or we might find something that would say, gee whiz, if you just start this kind of exercise, you might really be taking a risk with your life. I remember there was a very famous author who wrote books about you should exercise and it doesn't matter. Forget about checking yourself out, first.
Mm-hmm.
And he kept writing that until the very day he died while running. Mm-hmm. And you cannot count on warning symptoms. And it's like anything else out there. Common sense should prevail. And,
Right.
Unfortunately, many people go through massive workups. This is not necessary either. Common sense should prevail. Look at family history. Have a reasonable history and physical exam. Perhaps a calcium score. Perhaps in certain cases a treadmill test. And baseline blood work. And I think with that, you can get a good idea of where you are and perhaps screening, colonoscopies at times, and if one's a smoker, clearly a chest x-ray. Sounds like a lot, but it's really not a lot if you're talking about the rest of your life and keeping yourself healthy.
100%. Well, in honor of Men's Health Month, we wanted to touch on these things which impact men's health and more importantly, their cardiovascular state and ways that they can get ahead of things and prevent some of these problems from occurring. And it sounds like just visiting your cardiologist or your physician to get the history discovered and then get on a path is the way to go. So, Dr. Walker, thank you for again just laying it out so clearly and so specific.
Thank you, Terry. We didn't even speak about getting a PSA to make sure a man doesn't have prostate cancer, but that's not usually something that kills us. Even though we get prostate cancer, it's a lot less. But today I thought we would really focus on cardiovascular disorders because overwhelmingly they're the number one cause of death in this age range of men.
Very nice. Thank you very much. I hope everybody enjoyed this edition of Cardiovascular Matters. We'll be back next week with more men's health issues and their treatment. Thank you for joining us here at Cardiovascular Matters. So if you're a patient out there and you've tried everything else and you just can't get the weight off, look into this. I mean, he's easy to reach at www.cardio.com. Everybody have a great week, and thanks for listening.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.